It's a great treat to have Dr. Mckee here. He's been, I think, at every course, if not pretty much almost all of them. He doesn't really require, for most household orthopedic surgeons, doesn't require any introduction. He's well known throughout North America and internationally for a lot of his work. Has won multiple research awards from the Orthopedic Trauma Association, and has contributed in a very significant way to our understanding of upper extremity trauma, amongst other things. He's an amazing speaker and warm person and wonderful friend. This lecture that he was invited to give is entitled Orthopedics in 2024, a view from both sides of the 49th parallel. It's an update from his OTA presidential speech, which was outstanding, and thought that this would be a wonderful opportunity for him to share this with our group. So with that introduction, Mike, thank you so much for being here, and look forward to your chat. Thanks. Big round of applause for Dr. Mckee.
Thank you. Thanks very much. Thanks, Ted. That's a very nice introduction. So I'm going to talk a bit about my experiences with orthopedics in 2024 from both sides of the border, and by that I mean the border between Canada and the United States. And I'll talk a little bit about what I think qualifies me to discuss this topic. I have some intrinsic biases like everyone, and they may become apparent in this talk. I'd also encourage people in the audience, if you have questions or things you want to ask about, then feel free to do so. And if you think I'm being unclear or straying off from what is actually accurate, then feel free to put your hand up, and I'm happy to stop and talk about that. So the 49th parallel is the border between Canada and the United States. It's about 5,225 miles long, and it's often described as the longest undefended border in the world, which it is, frankly, if you look at what's happening around the world today. Fortunately, we don't have to worry about one side transgressing over the other or not. And in general, it's been a fairly stable relationship between our two countries over the years. I'd point out, if you look at this map, that roughly 90% of the population lives in a strip right along the bottom of that map. So the vast majority of our country is pretty much uninhabited, and there's a 90% of the population in a 100-mile radius or 100-mile distance away from that border along the United States there. So obviously that's where most of what we do is concentrated and focused. Well, what qualifies me to talk about this? I grew up and trained in Toronto, Ontario, which is Canada's biggest city, and I did my residency there. In 1993, I left and did a fellowship at the Massachusetts General Hospital with Dr. Jesse Jupiter, which was really an eye-opening experience from a number of different aspects, not only the orthopedic or medical part of it, but also the economic or business and political part of it. I have to say that as a resident, I was abysmally ignorant of the economics of orthopedics and medicine. I didn't have any formal training in it whatsoever. I didn't know about how to start a practice. I didn't know about what costs a lot, what didn't. I didn't know what was considered value-based, which is a very common term now, and what wasn't. I can remember as a resident seeing patients get admitted to hospital for a total hip replacement, getting their surgery, lying in bed for 5 days, bed rest for 5 days, and on day 5 we take the dressing off, and that'd be the signal for the physiotherapist to get them up and moving, and they would stay another 5 to 7 days after that, depending on what their circumstances were. So that was absolutely standard back in that day. I went to the Mass General, and they were at a much more rapid program, and I said to Jesse, why is that? And he said, because it's just as good and it costs less. And that really resonated with me because I'd really not thought about cost much before that. So that was a very eye-opening year for me. When I finished my year there, I came back to work at St. Michael's Hospital, which is Toronto's downtown core teaching hospital, known as the Urban Angel is the branding that they've given it. It's a large teaching hospital. It looks after all of the level 1 trauma in Toronto that happens in the southern half of the city. In the north half of the city, all those patients go to Sunnybrook. But it was very much a local population type of people that the hospital looked after. There's a long street just north of it called Shooter Street, And we consider ourselves the team physicians for the Shooter Street All-Stars, as we used to call them, and you can imagine what that population is like. Those of you who worked in downtown core know it's probably not a whole lot dissimilar for you. During the next 25 years or so, I worked at St. Mike's, but I traveled extensively. This is a picture of the ABC trip that we took to England with a number of American, and ABC stands for American, British, and Canadian traveling fellows. You can see Dr. Mckee in the back room there. You can see Dr. Turnetta, Paul Turnetta, the current president of the AOS, in the front. We just had a shooting match where the British and Canadians and Americans squared off in a reenactment of the War of 1812, and you can tell from the look on Dr. Turnetta's face, he won it in this skeet shooting competition with a spectacular last shot, so tipped the balance in favor of the American group. But I had a very close interaction. I traveled a lot in the States, did a lot of research with people in the States, so I was really always very interested in what was going on down here. On a personal level, I have a fairly large family. I have children born in Canada. I have children born in the United States. I have a lot of American relatives in that regard, and overall I think we're in a pretty good position, at least I'm in a pretty good position, to talk about what the differences are between the two medical systems, especially since 2017. So I was becoming very frustrated in my practice at St. Michael's Hospital. It's a great hospital and the people who work there are good, but they're stuck in the system which was just very stagnant. And as an example, I do some elective shoulder replacement surgery. When I left St. Michael's Hospital in 2017, my wait list for a shoulder replacement surgery was 2.5 years. So you'd wait 6 months to come and see me, and then I'd say, yes, Mr. Jones, you need a shoulder replacement. Great, when can I have it done? And I say, well, about 2.5 years from now, you should come up on the schedule. Because we were rationed as to how many we could do. Regardless of what the demand was, there was no way to increase the numbers of surgeries. It was a purely single-payer public system. You had a set number of OR days. You had a set number of dollars you could spend on shoulder replacements, and that was it. And we did everything in our power to trim the case cost for a shoulder replacement down. We didn't use any of the fancy stuff. We didn't use sponges in the canal. We didn't use extras on the set to try and minimize the case cost, because that would allow us to do a few more per year in the set budget. So in 2017, the opportunity of becoming the chair in the Arizona College of Medicine in Phoenix became apparent, and I applied and was accepted, and my wife and I went down to work there. And so it's been a real great experience for us. It's been a good move on a number of different levels, especially professionally. So I think that overall, hopefully I convince you I've got a pretty good balanced view of both systems to talk about in today's session. People often ask me, what's the difference between a Canadian and American? And really, there's not a lot. The vast majority of people in both countries are friendly, open people. It's a diverse group in both countries now. And really, it's, in general, a pleasure to live in either spot if you look at some of the places around the world. But I think the one thing that really is different is, by necessity, Canadians know a whole lot more about America and Americans than Americans know about Canadians. And that's only natural if you live beside someone who's 10 or 12 times your size. And an example of that is, back in 2017, in Canada, during a hockey game, when the American teams play, they play the American national anthem before the game, and then the Canadian one, both national anthems. In the middle of the American national anthem, the mic for the speaker cut out. And the 18,000 Canadians in that stadium finished the American national anthem without a hitch. You can go online and look at the videos of it, but word for word, finish the American national anthem. Now, I ask you, if the same thing were to happen in an American arena, how many people here could finish the last half of the Canadian national anthem without? Yeah, I see people shaking their heads. It'd be tough. So that's kind of the gist of it right there, is that we know more about a person who's 10 or 12 times your size than Americans know. And that's the main difference, I think, between the two groups. And I found this was a very amusing kind of anecdote. Well, how did we get to where we are today in Canada? So this is Tommy Douglas, and he's one of the more revered figures in Canadian history. And most of you probably don't know him, and reasonably so. When he lived in a province called Saskatchewan, and when he was 8 years old, developed osteomyelitis of his tibia. So he had this tibial infection. He had multiple surgeries to try and drain it. They were unsuccessful, and the local doctors recommended that he have an amputation done. And out of desperation, his father contacted a surgeon in a bigger town who had some expertise in this area and said, you know, my son's facing an amputation. Can you come and help and do anything? And so this surgeon agreed pro bono without being paid to come and do this, and did an operation or two and saved the leg. And this had a profound effect on Tommy Douglas and his family. And he said later on in his life, although he wasn't consciously aware of it at that time, the seed formed in his mind that, you know, the survival of someone's limb or the patient themselves should not depend on the patient's ability to pay for it. It should be a basic right in a developed country that you have to have that kind of care provided to you, regardless of your ability to pay. And that was the beginning of the concept that perhaps a universal payer system might be reasonable. As luck would have it, he was very successful politically. He ended up becoming the premier, which is like the governor of the province of Saskatchewan, and he introduced a single-payer universal health insurance plan at that time. So he said everyone in Saskatchewan is going to be covered by a single-payer plan that we're going to provide at actually minimal cost, be paid through tax dollars, et cetera. And if you get sick, if your tibia gets infected, or if you get hit by a car, we are going to pay for you to get better, and it's not going to depend on your income or your ability to pay, which sounds like a pretty good idea, and it was considered a pretty good idea by most people. And I have to say, he belonged to a political party which should be considered even to the left wing of the Democratic Party here. So it's a very left-wing party he belonged to. But everyone said, yeah, this is probably a good idea. Before that, it was a hodgepodge of private payers and insurance plans and individual plans, et cetera. You might not know Tommy Douglas, but interesting, this is his son-in-law, Donald Sutherland, and his grandson, this is Kiefer Sutherland. So he comes from a fairly distinguished family down the road. So what happened? Well, the Saskatchewan doctors were very upset about this. In fact, there was a doctor's strike that lasted a few weeks about this whole plan. And this is an exact quote from a newspaper at the time. They said they complained about being turned into civil servants. They wouldn't be able to follow their own judgment. Someone else would make the decisions for them. This was a slippery slope down into socialism. And some of this sounds familiar if you look at what we're facing today, maybe not with socialism, but with insurance companies, et cetera. But there was a lawsuit started, or a appeal against this system that went all the way to the Supreme Court of Canada, and where it was decided eventually that this was going to be a reasonable thing to do. So the doctors who were involved in that province at that time were actually bitterly opposed to this implementation of this plan, and eventually had a strike over it that didn't last very long before people eventually said, okay, I guess we'll have to go with the flow. So what happened next was this quasi-judicial hearing about, well, it seemed to work okay in Saskatchewan. Should we introduce it in other parts of the country? And it went right to, again, the Supreme Court of Canada, where an official commission was launched, the Royal Commission on Healthcare, and it was run by this person named Justice Emmett Hall. And they sat down and looked at all the pros and cons of this proposed system, and should we introduce this across the entire country, and is it worthwhile? Is it legal? You know, can we deny patients having private care, that kind of thing? And eventually it was accepted, yes, this was a good thing, and eventually that Saskatchewan plan went nationwide and became the Canada Health Plan, or a variety of different names, but basically a single-payer universal system going forward. Justice Hall also has an orthopedic connection, so those of you might recognize his son, who was John Hall, who was a major pediatric surgeon in Boston for a number of years, that was still practicing there when I was there back in the day. So what do we have right now? So basically, for a nominal fee in registration, you have access to essential medical care, all the surgery, not cosmetic surgery, that's excluded, and there are some exclusions, but the essential surgeries, which are carefully listed, your hospitalization, et cetera, is all free of charge. There may be a small number of user fees here if you need a special splint, whatever, but essentially your ICU stay, your surgical stay, all those things that really drive up the bill here are covered by the government universally. So you get an OHIP number, and OHIP is the Ontario Health Insurance Plan, and they cover all the surgery for you. It does not cover dental work, although just recently there's been a national introduction of a dental plan. Most drugs aren't covered, physiotherapy, cosmetic surgery. So there are some private things still, but essentially all the things that we do, joint replacement, fracture fixation, arthroscopy, et cetera, are paid for jointly by the provinces and the federal government. In that environment, there is an ongoing debate between those two entities, like the debate you see here in the States between the federal government and the state government, a lot of conflict back and forth. And at the present time, for example, in the province of Ontario, we have a Democratic federal government, but a Republican provincial government, so you can imagine the grief back and forth between those two entities. And both groups are always saying, we pay for most of the health care, the other group should pay more. And it's all about battling over tax dollars, et cetera. So there's a lot of back and forth about who should pay for this, who's paying more. The federal government says, hey, we increased transfer payments by 6% last year. The province says, yeah, but our expenses went up 12%, we need more money. And it's this constant back and forth, each group trying to maximize what it does and minimize what the others take credit for. So that's the backdrop of what's going on at the present time. Well, that plan was introduced around 1970 or so. And if you look back then, in 1970, there was very little arthroscopy. So Bob Jackson, who went to Japan to work with Professor Watanabe and learn about the arthroscope, was just bringing that back into North America around this time, but there was very little arthroscopy. Joint replacement was in its infancy. The number of joint replacements done was minimal. Spinal surgery was rudimentary at best. There were no expensive implants. It was just washing out pus or maybe decompressing a level and hoping things didn't fall apart. And fracture care was predominantly performed with casts and traction. Okay? So that was 1970 when this plan was introduced. If you had a clavicle fracture back then, you got a sling, which maybe wasn't the best treatment for you, but it was cheap. So what we did in 1970 was cheap. We didn't have all the things we have now. We didn't have a TAVI, an artificial valve, at $50,000 a pop. We didn't have those things. And so what you were spending on your population was relatively limited, in fact, extremely limited compared to what we have now, where there's all kinds of options. Now you might get a plate for your clavicle, which is better for you, maybe back to work quicker, but it costs the system a lot more money than a sling does. And so that's a major issue going forward. If you look at the explosion of technology that we have and the government has to pay for. Additionally, there's significant demographic changes going on in both countries. If you look at the mean age, if you look at 1970, that we bottomed out, the mean age was around 24 or 25 years old. We were a healthier, younger population, just like in the States. Now we're an older population. There's a much higher incidence of comorbidities. We're living with diseases now, not dying from them. We're living with transplants. We survive cancer. We get expensive chemotherapy. We develop secondary cancers. We get renal failure from whatever. It's a much older population with a much higher rate of comorbidities. So if you look at those two factors alone, the cost of healthcare, of what we can do for somebody, and the general health of the population, they're both going in bad directions if you're an economist. So everybody has more problems to deal with. It costs more to do it, and we have way more options now to do it. So now we're reaching the point where we simply can't provide everything for everybody based on what we're taking in tax dollars. So if that's the case, and this is economics that would make a trained economist cringe, but it's very simple. We're spending more than we take in, and something has to give. So you either have to jack the tax rate up, and we already have one of the highest tax rates in the world at over 50% for the high margins, or you have to make things cheaper somehow, and that's been very difficult to do, or you have to ration care. And the bottom line is the way that most of the healthcare budgets in Ontario and Canada have developed is the rationing care, which is why the wait lists are so long, which is a critical feature going forward. The Journal of the American Medical Association is a fairly high-impact journal. I think the impact factor for JBJS, our major journal that most of us read, is around 5. I think JAMA is around 120 or so. So it's a very, very important journal. In 2019, these two authors, who are essentially academic authors, I don't think they have much of a clinical practice. They wrote this very important viewpoint saying we should make Medicare available for everyone in the United States, make it a single-payer system, eliminate all this extra that we pay for administration. And it's quite true that the United States pays more for the administration of its health care than any other country in the world. Look at the percentage growth of GDP, the absolute value. Any way you look at it, the U.S. spends more for healthcare, for the administration of healthcare, not just the actual performance of the administration of healthcare, than anyone else in the world by a long shot, not by a little. And what these authors said was that you could dramatically decrease administrative costs, you provide more equitable access to care, you could standardize things and have some control over the standardization to help decrease costs, and you could do some global budgeting to control costs. Global budgeting is this. As a government, you go to a hospital, like my old hospital at St. Mike's, say, St. Michael's, we expect you to do X amount of work this year, and we're going to give you $300 million to do it. And that's it. If you go over that, you're going to go in deficit, or you have to find some way to cut costs. We have some basic minimums that you're going to have to meet, but if you want to do extra surgeries, we're not going to pay any extra money. And so it's a bit of a disincentive to do extra work, whereas in most US-based institutions, if you do a case, it's like a paying customer, you get more money from it. My hospital gets money per joint it does, and so it's always on the lookout to do more joints, reasonably so. In Canada, it wasn't like that. It's a global budget, and that controls your cost to a certain extent, because your payer knows, I've got a fixed amount I'm going to pay this hospital. It's going to be, that's it. I don't have to go over that. And so this entire article was a major proponent of converting the system we have now in the States to this single payer system for all, but it ignored a couple critical things. I wrote a letter back to the editor saying, what you say is true, all those things you say are true, but there's a couple things that you didn't mention, and these are like the complications from your operation, so to speak. In any way you measure it, in terms of accessibility to care, Canada is dead last in the world. You look at, the G7, you look at the group of 20 developed nations, you look at almost anything you look at in the industrialized world, Canada comes dead last in accessibility. Longest amount of time to see your primary care physician, the highest number of people without a primary care physician, longest time to wait for elective surgery, longest time to wait for cardiac surgery, et cetera, et cetera. We are literally dead last in every one of those polls that have been done, and there's reams of literature if you want to look up at that. And the second thing is that we train an appropriate number of orthopedic surgeons for the population we have. There's 15 or 16 good training programs in Canada. We train excellent orthopedic surgeons, and we have the appropriate number of trainees for the population we have. The problem is once they finish, there are no jobs for them. So a job gets posted in, a Toronto hospital, there's 50 or 60 applicants for that position. Most Canadian residents now do 2, sometimes 3 fellowships because they can't get a job. And the way that's controlled is the hospitals don't have any OR time, don't have any beds, and don't have a clinic space. So that's the limiting factor in getting a job is there's no OR time. In many places, when you do get a job, they say, yeah, we're going to hire you, Dr. Smith, great to have you. You're going to get 1 elective day a week. That's it. Some places it's 3 days a month. So you get 1 elective day a week, and the 4th week you get nothing, as a way of trying to contain costs because they can't add more people to a fixed budget. There's no way to do that. So I wrote this letter saying everything said is true, but those 2 things remain a major problem. What is some of the information to support that? If you want to look this up, it's all in the various forms of literature. This was Canadian Journal of Surgery that Ed's the editor of, talking about surgeon unemployment in Canada. Underemployment or unemployment, where you have a job but you don't get enough resource or you're not employed at all, et cetera. That's one of the reasons why you see so many highly trained Canadian surgeons coming down to the States is because they're well trained and they have a number of fellowships and they're happy to have a job, frankly. And I've got some of my staff, there's some of the staff here in San Francisco, and it's a shame that we don't have the resource to keep them where they're trained. And there's a whole bunch of literature on this. The Canadian Orthopedic Association actually put out a position statement saying, this is bad and we need to do something about it. So that's a reality of that single payer system where there's a rate limiting step of resource in terms of surgeon employment. What other countries in the world have a single payer system provided by the government with no private medicine? These 2, North Korea and Cuba. Probably not 2 countries you want to emulate if you look at healthcare delivery. But nowhere else in the world is there a single payer system with no private avenue. I'll talk a bit about the private avenue in Canada now, which has become a little bit more open than it was before, but these are only the 2 countries that have a system like that. Dr. Brian Day, some of you may have heard about, he's an orthopedic surgeon who works in British Columbia. He ran a private clinic for years and was kind of constant battle with the government back and forth about the private clinic he had. And it was against the Canada Health Act, and the way the federal government enacts that is that if there's private health care going on in your province, We're going to figure out how much was delivered. We're going to hold back that same amount of money from transfer payments. So if we figure out in British Columbia there was, $100 million worth of private medicine practiced against the rules of the Canada Health Act, next year we're going to hold $100 million back in transfer payments. And Brian, and he was the guest speaker at the OTA meeting in Vancouver, I think 2018, gave a great talk about this. But essentially he sued the government in British Columbia. He said, it is not constitutional or right for that matter to put a monopoly on a service and then fail to provide that service. Now, some of the examples he had in his case were horrendous. People waiting 4 years for scoliosis surgery. It had occurred when it was 50 degrees. By the time they got to surgery, it was like 80 degrees. And we know that it's a harder operation, more blood loss, much more difficult to correct, et cetera. He had a number of cases like this. And his case was based on a famous Quebec case. So Quebec is another province in Canada where a lawyer actually, went to his family doctor and said, I have hip pain. Family doctor said, okay, takes an x-ray, he's got bad arthritis. I'm going to refer you to an orthopedic surgeon. The lawyer in Quebec waits 1 year to see the orthopedic surgeon. And the orthopedic surgeon says, yeah, you've got bad arthritis, you need a hip replacement. The lawyer says, great, I'll take the hip replacement. I mean, it sounds like a joke almost. The doctor says, yeah, it's going to take two and a half years to get you done. And the lawyer says, what the heck's going on here? I'm going to wait 3.5 years in my problems to get a hip replacement? I'm going to sue the government. So this person, Shauli, sued the Quebec government, lost, appealed it to the Quebec Supreme Court, lost, appealed it to the Supreme Court of Canada, and won. So but the Supreme Court of Canada was very specific in the decision saying, if you have hip arthritis in the province of Quebec, you can seek private care for this, but everything else we're not going to open up. So Dr. Day was very hopeful that this would go through the system in the same way, and when it got to the Supreme Court would say, yeah, there's a precedent here, the Shauli principle, which is why now there's a little sliver of private health care in Quebec, and it's just the same for spine surgery in BC or cancer surgery in Ontario. If the government says we're going to put a monopoly on this service and then doesn't deliver to the people what it promised to deliver in a timely fashion, that's unconstitutional. Unfortunately, after all that, the Supreme Court just came back about 6 months ago saying, yeah, we're going to say no to this. It's not going to go through. So that basically his long challenge, which a number of us contributed to financially, because there was a lot of issues here with the process. And as an aside, the British Columbia government used every possible obstruction measure and abusive process that a big firm would use against a small person lawsuit, such as sending him 60,000 pages of documents the day before the trial started, stuff like that. And still he lost, which was a big disappointment for all of us. What about COVID? What impact did COVID had? Well, I'm not much of a mathematician, but if you have a set demand which is already outstripping your supply, and then you stop the supply completely, and some of the shutdowns in Canada were draconian. So Canada had a much more conservative approach to COVID than America had. We shut hospitals down for 3 or 4 months sometimes. There's no elective joint replacement for 3 or 4 months in some hospitals. And that was common, and it happened a couple of times actually. In my hospital in Phoenix, we slowed down for about 2 or 3 weeks. Now maybe we weren't hit as bad as COVID, or maybe we're a bit more cavalier about it. I don't know what the right answer is. But we slowed down for a couple of weeks, but really never stopped doing elective surgery. Whereas in Canada, the restrictions were much more dramatic. Now, you could argue the pros and cons of that. In my own opinion, I think sometimes we let the cure become worse than the disease at times, but still, that made a huge impact as well. So the wait list just skyrocketed during this whole COVID crisis and made things a whole lot worse, unfortunately. This is a letter that came from a Calgary paper, and there's a couple of issues with this one. This is a person talking about his father who needs a hip replacement. He told them, the patient was told, yeah, well, you'll get a hip replacement 12 months after we meet you. COVID-19 came. They said, oh, yeah, your wait list just doubled. It's going to be another 12 months, and et cetera, et cetera. The whole time this is going on, you have to remember, the whole time this is going on, the patient's function and the patient's x-ray and the difficulty of the operation are all getting worse and worse. And we know that. In fact, there's studies in Canadian medical literature looking at what are the effects of a delay on a hip replacement. And we do those studies because we have a huge population that got a delayed hip replacement. So we know what your function was like at the beginning when you went on the wait list, and what your function is like when you finally get your operation 3 years later. There's a tremendous deterioration in your function. You get muscle atrophy, you get joint stiffness, you don't do much anymore, your cardiopulmonary reserve goes down the crapper. It's all bad. We know that. And this is what this letter is talking about. So this person decided to send his father to Phoenix to have his hip replacement done. So I do joint replacements regularly in Phoenix for Canadian patients, some of my old patients from Toronto or patients from the Western provinces who come down, pay a set fee, and get their joint replacement done by myself, and then go back and looked after by their local doctor. In the province of Saskatchewan, which is Tommy Douglas's old province, the waitlist for a shoulder replacement now is like almost 3 years. And I did a lady last week last month who'd been on the waitlist for almost a year and a half, and she said, I can't take this anymore. I'm going to pay the money and come down and get it done. So, and this is all public knowledge, I can do a shoulder replacement primary on a relatively healthy patient for around $20,000 or $22,000 US, all figures US, and pretty much everyone's happy with that. My hospital's happy, I'm happy, the patient's happy, etc. And this person here went to Phoenix to get their hip done for $44,000. Now, I don't know where it was done in Phoenix, but I'm pretty sure we could undercut that price. I feel like calling that guy saying, next, when you get your other side done, come on and see me. We'll cut $10K right off the top. But that's a regular, in fact, my hospital now is developing a concierge service, so to speak, looking at bringing patients down for various types of surgery, including spinal surgery. As an aside, about 2 years ago, the province of Manitoba said, we are having real trouble getting spinal surgeries done, elective spinal surgeries done. We're going to contract with a hospital in North Dakota to do 300 spinal surgeries electively. So the government said, hey, we'll take care of this because we're so backed up here. We know people are literally going paralyzed waiting for, spinal surgery. They had the contract going. I think they did about 150 cases. Everyone was happy again. It was high quality surgery, low complication rate. It really helped the patients. The government, the provincial government in British Columbia changed, and I'm paraphrasing here, but from a Republican government to a Democratic government. The next day, the Democratic government said, okay, that's done. We're not doing this anymore, and stopped the program as a political thing. So you can read about that in the papers if you like. One thing that's always amused me is that the people, the politicians in Canada who say, our system's great, don't go down the States, it's so bad, you pay so much for care. Stay here and have your surgery here. Our system works okay. It's a bit slow sometimes, but it's okay. When they get sick, they cannot get on a plane fast enough to get out of town and get looked after, okay? These are both headlines, so this is all public knowledge. One was the premier of a province who developed chest pain. And so he got on a plane to Miami the next day and went down and got a Miami procedure done. And when he came back, and people said, hey, what's going on here? He said, oh, they don't have the procedure I needed available in my province. And the day after that, of course, there were a dozen letters from cardiologists in his province saying, yeah, we have that care here. You just have to wait for it. And that was, not what he wanted to do. So these are, and there's literally example after example of this where, politicians are all the same to a certain extent, where they support the public system, but when they or one of their family members gets sick, they literally cannot get out of town fast enough to get looked after. Andrew Fury is an orthopedic surgeon. He's a great guy, a friend of mine. He is an orthopedic surgeon who's in the OTA. His family has a history of political involvement, and he was named the premier of Newfoundland and Labrador, which is an eastern coast province here. And I had a couple of discussions with him around that time, and one of the things he impressed upon me was that the difficulty in making an effective change when everyone is convinced their system is good. And it's taken a tremendous amount of time for people to realize maybe this universal payer system isn't the greatest thing for all of us. And he's done actually a great job, I think, with a province that has a lot of issues and a huge deficit, the usual thing. But if you catch him at a meeting, ask him about what his experience is. It's very enlightening, and he certainly knows a whole lot more about it than I do. Well, how bad is it? Now, there's always sensationalistic headlines that you can pick up, and there's similar stories in the States. But it's gotten so bad in some provinces, and it seems like the East Coast, for whatever reason, is one of the particular ones, is that on occasion, patients who are young and healthy with a correctable problem will go to their local ED. So it's not just orthopedics, but it's also in other areas as well. And they simply don't get care for hours and hours and hours until they literally die in the waiting room. So there's 3 cases like that in the province of New Brunswick, and it caused a massive shakeup in the government. But it's just a symptom of how bad the waiting lists are and how difficult it is to get care there somewhere, sometimes in certain areas in the country. So So here's where we get very simplistic. So people say, well, you know, you're great at talking about what all the problems are. What's the solution? And there's no easy solution. And greater minds than mine have thought about this over and over again. But in the most simplistic way that you look at it, I think healthcare delivery should be something like this. And of course, there's lots of obstacles with this. It's like getting on a plane. Your government should provide you with a good, sound airplane to fly on, with a pilot and a crew that know what they're doing. So competent pilots, a good airplane, going from A to B, and you sit in, like I did last night, in row 25 with my knees jammed up against my face in economy, okay? That's what the government should provide for you in healthcare. And that's, you're gonna get, I got here safe. It wasn't the most comfortable trip, but I got here safe, no problems. If you wanna upgrade to business class on your own dime, feel free to do so. There should be an outlet for that available. And most of the countries in the world that have a pretty successful healthcare system, like Australia and now Britain to a certain extent, et cetera, have that kind of system. We're going to provide you with good basic care, but if you want it a bit quicker or a bit better or by a certain person or with a certain implant, feel free to pay for it on your own dime. There should be some insurance plans that allow you to do that, or you can do it on your own nickel. It's whatever you want to do. That's what I think probably is the solution. Now, there's all kinds of issues with that. If you institute that, you'll have doctors flooding out of the public system and the private system. Britain has dealt with that to a certain extent by saying there's 10 blocks in the week, 5 days a week, morning and afternoon. You have to stay in the public system, 8 of those or 9 of those. You're allowed to do private on your own time after that. There's ways around that, but I think in the very simplistic way of looking at it, that's what's available. In Canada right now, there's a little sliver of private care, which is available now, especially in Quebec, which has that precedent ruling I talked about, and which has always been a little bit different in terms of healthcare, but it's very limited. But more and more people are becoming interested in that because the status quo is not sustainable. So the only plea I would make is that if it's decided by the powers that be that we're going to go to a single payer system in the United States, that just keep in mind what the pitfalls are of that going forward. And there will, of course, be tremendous opposition to that from insurance companies, et cetera, and they're the ones who seem to be making all the money these days as we get, you know, chiseled away every day in what we make, and as hospitals go bankrupt all over the place. To my very simplistic way of reading headlines, it seems the only people who are making a lot of money right now are the insurance companies, record profits, et cetera, while rural hospitals close. Could argue about that. But if it happens, just be aware that there are some pitfalls having that universal payer, single payer system. So that's a lot. Some of it's a bit controversial. Some of it may not be accurate. I'd be glad to hear what people's experiences are from the audience. And thank you very much for your attention. So, questions or comments? Dr. Rosenwasser. There's no way I'm ever running for political office, that's for sure. I can tell you that. Economy class ticket, yeah, okay. Thank you. Thanks, Mel, appreciate it. Dr. Shemitz.
I would always pay to hear you speak, Mike. I'll say that right at the start. I guess one of the questions I have is just around evidence. So, for example, if you look at like measures of health, if you look at Canadian life expectancy, it's higher than in the U.S. If you look at fetal mortality, it's lower in Canada. If you look at maternal mortality, it's lower in Canada. So given that the overall stats would suggest that the Canadian population is actually healthier, how can you account for that given the talk you've just given?
So a lot of that's not so much medicine per se, but public health as well. And I would argue the solution is that you can maintain those figures, but improve the other things we've talked about. There's always room for improvement. And I agree with all those things you say, but a lot of that's societal and not just public health in terms of outcomes that you talk about. In addition, I don't see any reason why you couldn't maintain that high quality of public health care, et cetera, but also get someone who needs a hip replacement done earlier than 3 or 4 years later after you see them. That'd be my argument. And I think that if there's money coming from a private source to speed up that process, I think that'd be very reasonable to do that. And you know, we've talked about this before in terms of the COVID crisis. More people proportionally died in the States of COVID than died in other countries, and that may be along those same lines. Ted?
Yeah, hey, Mike. So first of all, the only reason I'm up here is to apologize that you had to sit in Coach you know, we're on a limited budget here on this the course,
okay.
and I hope you enjoyed.
It wasn't a personal criticism.
I hope you enjoyed your apricot tart. Okay.
It was very nice.
But my son is a fourth year, as you know, medical student, and we had a debate about this very same thing a couple days ago, and he was sort of extolling the idea that we spend too much money in this country. So clearly, I think the Canadian system is on one pole, but our system is also difficult to sustain, and it isn't so much those who can afford to pay for it here. It's almost those who can't afford to pay for it here that really suffer. And I'm sure you see that, you know, now in Arizona. So what do you think is the right mechanism to try to get people who need the care to get it to a good enough degree where they're in that safe airplane, but still be able to have a system that can afford the very, very expensive pathway that it's on? So it's almost like, what do you think a potential solution? I know it's way too hard to come up even in 10 minutes, but little nuggets of thought about how we could improve the system on either end to make care more equitable for everybody.
Well, like Bob O'Toole says, I'm a social critic without a solution. So it's easy to criticize, hard to have a solution. But again, I think that if you look at the amount of money that the U.S. spends on administration of healthcare, not the actual healthcare itself, but administrating it. Like, look at the size of the buildings the insurance companies have offices in. They're the biggest buildings in most cities, and the number of people they employ, et cetera. In actual fact, none of those people, right, actually do anything for your patient. It's all pushing paper back and forth and denials and approvals and all that kind of stuff. And that's a very gross oversimplification. But none of them are actually, you know, looking after a patient. I'd have to think, if you look at those costs, the administration of care, there's got to be a better way to do that in this country than what's being done right now. That's what I would say. That's where I think the ability to improve care for everyone would come. If you took all that money, you know, the 18% of GDP, and you brought it down to 11%, like Britain or Switzerland or Canada, that 7% of GDP that you could eliminate in the pure administration of medicine. That's, you know, hundreds of billions of dollars. You could use that to make things better for everybody. And how do you do that politically? I have no idea. But that's what I'd have to think mathematically.
Yeah, so that's I think a point that a lot of our politicians sort of pointed to, and it's interesting. This is a comment, not any more question about it, and that is that their solution is that, well, maybe we should have a fixed payment system that the government sets. So it's going back to the single payment system.
Maybe as long as there's a relief, like Mel says, as long as there's a relief valve somewhere, that system gets overburdened, that'd be okay. Dr. Degan.
Just the comment Dr. Shemich had about Canada's outcomes being better than America. I don't think America is one you should compare yourself to, because they literally have some of the worst outcomes and they spend the most money on healthcare. So if you look at maternal mortality, America is literally rock bottom, and yet they spend the most. So they may be better than America, but if you compare to Europe, Australia, you know, they're definitely not winning any awards compared to those other places.
Yes.
Canada is obviously a divided country, not just politically, but I think if you
linguistically too.
If the microphone went out in the Vancouver hockey stadium, I don't think that the Canadians would be able to finish the anthem in French, which is what it should be. It's a bilingual country, so.
Dr. Harvey, you want to respond to that? En français, monsieur?
Yeah.
At least Dr. Harvey could. Yeah, that's a good point. I mean, there's a lot of divides there too. But you know, it's well, sure, we'll leave that alone. But yes, you're right.
But yeah, I agree with Dr. That you know, you measure a healthcare system by the worst care that people get, and I think per capita we probably have more people dying in the ER in the U.S. than we do in Canada.
Well, let's stick with that for 1 sec. So for me, that's if a homeless person gets hit by a car outside the hospital, where would I rather be, in my old job or where I am now? I'd rather be where I am now. That patient gets better care. Literally have access to the OR. I don't have to fight with everyone else again. I have a trauma room every day. That patient stays in house. I have a nurse manager to help negotiate where he's going to go to. Well, there's a state policy for trauma patients to get to a SNF. That is better than where I worked before. It's that simple.
Yeah, no, I agree with
And
you.
so, though that's, you know, theoretically for us as orthopedic surgeons, that's the worst case, is a homeless person with a bad open fracture. That person gets more prompt care and better care from me now in Phoenix, Arizona, than I used to be able to do in my old hospital. It's that simple, because there I was fighting for that OR time with everybody. I start that case at 3 o'clock in the morning after the C-section finished and after the craniotomy finished. Now I don't do that. I have time during the day. There's a huge difference there.
I agree with your point, but I was concerned about your statement that said there wasn't any good solution. I mean, there is a good solution. There shouldn't be a restriction on physicians in Canada only being able to practice private or public.
Right.
It happens in France, Australia. Doctors are working in hospitals that are public hospitals next to private institutions. They spend a day or two working with the residents, doing cases there, and the rest of their week is spent doing private work, and patients pay the premium for being in a private hospital, having their surgeries done sooner. Why can't that happen in Canada? I don't understand.
I agree completely. I barked up that tree for 25 years. I said, look, my operating room sit empty on the weekends. I've got nurses and anesthetists be happy to come in for a few extra dollars and do 4 total shoulders on Saturday. Everybody leaves the hospital the next morning. The beds are free on Monday for whatever else we have to do. All you have to do is that, and those patients who get done privately, they get off the main list, so everyone, you know, advances by doing that. Couldn't get a sniff, never. It's like, the implication there is that some people are going to buy their way to the head of the line, okay? And for a Canadian politician to agree with that, that's like touching the third rail. They're done. That simple. Okay, thank you very much. Appreciate it.